Good afternoon, everybody. Welcome to the first of this afternoon sessions at Therapy Live Sport. Talking all things gym, we have the very fabulous Jack March with us, also known as the rheumatology physio, talking about managing away in the gym Goer. I will, before I introduce Jack and let him carry on, introduce you or tell you a little bit about our sponsor for this session. That is the rheumatology physio, led by Jack March himself. He's an advanced practice education project in general. Jack creates digital and printed resources to help you as an MSK clinician to recognise and refer rheumatology conditions appropriately. The rheumatology physio hosts the leading CPD course in the field. Click the banner below for 10% off courses. I do believe there's another pop out to do with a book that he's just released as well. So without further ado, Jack, I will hand over to you. Please do pop your questions in the question box and we will have a good discussion at the end of the talk.
Thanks, Gemma. See you in a bit. Hello, everybody. Thank you for making it after lunch. Hopefully you've had a good morning and filled out on some nosh ready for this afternoon. Keep you awake. I've got my coffee ready to go. So we are going to talk about managing osteoarthritis in the gym Goer today. So my aim is to make this super practical and super useful to anybody who is seeing someone who has osteoarthritis and is going to the gym, but hopefully you can extrapolate some of the information as well into other areas of your practice. So we'll talk about me very quickly, as Gemma mentioned. So I run rheumatology.physio and run CPD courses on all things inflammatory arthritis and connective tissue disorders, those kinds of things. And we have various materials, as Gemma mentioned, such as books, audiobooks, webinars, so on and so forth for you to get your teeth into. I still do work clinically, and you'll see the Choose Health circular logo there just next to the rheumatology physio one. And I do mostly second opinion work, which mostly centers around differential diagnosis, onward referral, that kind of thing, which is always good fun and keeps me interacting with patients, which of course is the main thing. So as we go through this, so like I said, we're going to try and keep this practical and really talk about the gym Goer themselves. So I'm not going to cover things in loads of detail like pathophysiology and different bits and pieces like that. So I do want to direct you to my little book that I have written, which I'm just sending you the little thing now. So it's about 10,000 words that I wrote, and it really goes through what my thoughts are on how osteoarthritis develops, why some people get symptoms, why some people don't, imaging, investigations, blah, 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 all those kind of things. As the little image shows there, comprehensive guide for you. Have taken 10% off today. I'm afraid I can't make it any cheaper than that, but I always do try. So if you want more information on osteoarthritis itself, then you can find that there. Pretty proud of that little book. Actually, it's done quite a good number of downloads. Lots of people with some good feedback. So I don't want to waste too much of our time talking about me and stuff. So we'll talk about osteoarthritis. So the first thing I want to do is gym goers are still human beings. So we've got a little person in the middle here of our diagram. They're still humans. They're still very complex. Even if we're just thinking about them in the gym environment, they obviously have most of them have other aspects to their personalities and their person. So as we think about, let's say someone's come to physiotherapy, osteopath, chiropractor, whichever profession we are, they come to us and they go, oh, I'm really struggling with this particular thing in the gym, and it's causing me a problem and I want to do something about it. And we decide, or it's been previously decided, that that problem is related to osteoarthritis. There's lots of things we need to consider as to what is going on in this person. Why are they struggling? Why are they struggling now? Why are they attending the clinic now? We know that osteoarthritis isn't really something that occurs overnight. So why have they decided to attend clinic now? And what are we going to do about that? So if we consider our biopsychosocial approach, as we have here in the diagram, then we're going to look first, just because it's at the top of the screen, not because it's more important, at the bio. So there will be an inflammatory component to the osteoarthritis, and this can be of an effect upon symptoms. So local inflammation can irritate and can cause symptoms for that person. We're also going to look at comorbidities, things like obesity, smoking, depression, anxiety, which will also come into psychological in a minute. These things can either increase the amount of inflammation or affect the nervous system, or both, and cause, let's say, either increased symptoms or an increased perception of symptoms as well from that osteoarthritic joint or joints. And then, of course, we do have structure as well. So at some point, I mean, we hate the term bone on bone, but if you've got reduced cartilage thickness or anything similar to that, you've got let's take a knee, for example, you've got some medial compartment osteoarthritis, and you've got a change in structure, then this can overload one area of the joint. You can cause focal overload, and you can get symptoms there as well. And we are aware of more recent research showing that you do get neovascularization into the cartilage of the joint when osteoarthritis is present. So that can be a pain generator as well. And then moving on to the psychological aspects, we already mentioned the more obvious depression, anxiety, and we know that those are related to pain levels. Or experience of pain. We also need to think about what is the understanding of this person's, what do they think is going on within their joint, and we'll talk about a little bit more about that in a minute. Is that making them fearful? What are their beliefs around what's happening, and is that going to be amplifying any of their concerns or any of the symptoms that they are experiencing, or amplifying the concern over the symptoms that they're having? And then, of course, we do also need to consider the social aspect of it. At the moment, we're looking at things like work, function, support system. If you've got someone with lots and lots of anterior knee pain, and they're a plumber who needs to be on their knees a lot, then that's going to be a very different situation to someone with anterior knee pain who works at a desk, in all likelihood. Is it that their function is being specifically affected? And obviously, we're talking about the gym today. So is it that actually they don't have a lot of pain, but the pain that they have is stopping them from a particular activity they like in the gym, and all of the associated issues that might come with that? And what is their support system like? Is it that they are the sole carer for a relative, or are they the sole earner? Again, going back to work for their family, what is going on there? And sometimes that can be a real driver of a lot of symptoms. So we need to make sure we're combining all of these things. And just because we're talking about the gym and particularly sort of things like lifting and those kind of things, then we don't want to be ignoring psychological and social factors related to that. So quickly to talk about pathophysiology, I won't go into loads of depth about this, but this feeds into our understanding of what's going on, but then also what is the patient's understanding of what's happening. If the person thinks that their joints are like a car tire, and the more that they use them, the more they're going to wear out, then this is going to be problematic. You can imagine you go to someone, you say, yeah, you've got osteoarthritis, and they immediately think, oh, I'm wearing my joint down, and therefore if I keep using it, I'm going to wear it down more, like my car, and eventually it's going to be completely unusable. And we know that this is not the case. So we know that the structural component is less related to the symptoms than we would think is obvious. So you can have some people with lots and lots and lots of osteoarthritis on X-ray and MRI and no symptoms and no functional limitation at all. And then you can have some patients who have no changes or very, very minimal changes, and they've got tons and tons of pain, really restricted joint range of motion, really restricted function. So we know that that's not the case. We also know that if you take large populations and you look at